Barbara is a professor of comparative policy and analysis at the University of Vienna, where she also directs the Center for the Study of Contemporary Solidarity. Barbara holds positions at the School of Social and Political Sciences at the University of Sydney, at the Department of Global Health and Social Medicine at King's College London, the Centre for Research Ethics at the University of Montreal, and at the Centre for Health Law and Emerging Technologies at the University of Oxford. Barbara is also intensely involved in policy-related work and is the chair of the European Group on Ethics in Science and New Technologies, which advises the European Commission. Barbara's work explores the social, ethical, and regulatory dimensions of genetic and data-driven practices and technologies in biomedicine and forensics. Her latest book is titled The Pandemic Within: Policy Making for a Better World, and her new monograph titled States of Solidarity: How to Save a World in Peril is under contract with the University of Press. So please join me in welcoming Barbara.
Thank you very much. Is this the microphone that I need to speak into? Thank you. So I will take the precision medicine part seriously and situate precision medicine first, and then talk about what AI does in precision medicine, and then get to the core topic, namely accountability. So some of you with whom I've had conversations about precision medicine, you've seen me share this slide, but I think it's important because, as we already heard in the beginning of this morning, if we talk about personalized medicine, many clinicians will say, well, medicine has always been personalized, if only because they have considered individual characteristics, circumstances of living. They have considered individual characteristics of their patients when doing diagnosis and making decisions on treatment, and also prevention to some extent. So this is this fantastic book by John Berger, Fortunate Man. This is really a book about personalized medicine. But of course, the evidence that we've used and the granularity of this evidence, the granularity of the stratification, and the evidence that has been used to personalize, those have changed greatly. And one big shift was, of course, in the aftermath of the Human Genome Project, when pharmacogenetics was the lowest hanging fruit. There was also a lot of pressure to show clinical benefits after this massive investment into the Human Genome Project. And this book by Adam Hedgecoe in 2004, this is really the symbol of a notion of precision medicine, where the matching of drug treatments to group markers of patients, group genetic markers of patients, was almost synonymous with personalization. So we see a kind of molecularization of the type of evidence that is being personalized. And then another change in 2016, then it was called the Precision Medicine Program in the US, introduced by then President Obama. It is now called All of Us. But that marked another shift, namely a shift from a very strongly genetically focused understanding of personalization to a multi-omics one. So this slide, which a lot of people have since used almost as a symbol for this idea, this vision of precision. This is, of course, not reality. I think this is such a rich slide because it really shows what the vision of precision was and still is for some people. One, in the report of the Institute of Medicine, but the National Academy of Sciences, they called it not a layover map, they called it a Google map, which is already very interesting. But the idea was that human health would become something like a Google map that becomes something that you can navigate. It has different layers of data. Here, individual patient data, microbiomes, epigenomes, and so on and so on. And then you integrate all of that, and then you create a map for navigation where the patient is ideally notified of problems before those problems occur. So the watch that warns you that something might happen before it actually happens. For that, you need, this is something that we don't talk about so much when we talk about precision, you need more or less continuous data capture. So some people called it in the beginning of the 2010s, the end of snapshot medicine. So data capture should take place not only when people go to the doctor when they have a problem, but it should happen continuously through wearables, through portables, and through disappearables. So that rhetoric has changed a little bit now. But one thing that hasn't, well, this is the scary slide that I also sometimes show. This was a vision in 2014 of all the data that would be integrated to create a comprehensive map of human health for individuals, that includes police records, ancestry data, and social media postings. So these are the key promises of the vision of precision. And here you can see that this is really a different iteration of personalization. It is one that is systemic and multi-omic. So it wants to put an end to the organ-specific medicine and organ-based expertise. So Leroy Hood's activities are a very good example for this. So systemic approaches, multi-omic approaches, not only genomics, but also a lot of behavior. The second promise was to close the actionability gap. This is a term by Nick Shork. So we know we know that the drug works in 8 out of 10 patients or 2 out of 20, but we don't know whether it works in a specific patient. So that's the promise to close that. And the third one, which we don't talk about a lot at all, is moving from symptomatic and episodic medicine, snapshot medicine, to continuous and pre-symptomatic medicine. And I think we can't understand the role of AI in medicine if we don't think about the third. So some of that vision is still there. Some of the vision to move towards a medicine that continuously monitors in an unobtrusive way and then acts almost without humans, requiring a lot of human input. I'm not saying that everyone working in the field holds this vision. I'm not saying that I was going to say system, but now after Angelike's talk, I say every tool tries to realize that. But I think this is the background vision of some developers and visionaries and policymakers and funders, without which we cannot understand what's going on. So it has been criticized. I think some of the most important critiques of that data-intensive iteration of personalized medicine by the name of precision medicine. We could also talk about why the Americans chose to move from personalized to precision. That's also an interesting story for another day. But Henrik Fogh, colleagues in Norway and colleagues called that vision of precision medicine that tries to bring together data from all kinds of sources to create a comprehensive image of a person, a digital twin, as Matthias told us, as technoscientific holism. So, and as you can see on the slide, they define it as the idea that each person's whole life process is defined in biomedical technoscientific terms, is quantifiable and controllable, and it's also underpinned by an idea of control that is holistic in that it's all encompassing, but there's still a lot that it leaves out. And we heard some colleagues already talking about relations, also the value of high touch, and the sort of expertise and experience that only humans can have. You cannot replace that by taking apart a human into their data points and put them back together. And again, this is not a takedown of precision medicine. I'm involved in many precision medicine related activities, but it's a kind of background to what AI does. So this is just a snapshot of many of the fields. They're virtually all fields around medicine and healthcare that AI has an impact on, from the most mundane tasks such as scheduling to treatment personalization and, of course, drug development. So I think it's fair to say that there's no domain in healthcare and medicine where AI hasn't changed things. And I think what is at stake, so I think this is by now a really interesting historical slide that illustrates the stakes. Part of the vision, and also related to this continuous medicine idea, is that ultimately AI in medicine will make things more effective and will make it cheaper. So during the Tory government, that was very clearly the program. If you remember the junior doctor strike in 2015, and people said they don't quite understand why the Conservatives are so hard-nosed, vis-a-vis the junior doctors, because we will need doctors, right? So in a very sort of in a side event to the Conservative Party conference, then Health Secretary Jeremy Hunt said that it was an explicit vision that we don't need so many doctors anymore because we will have machines. So this is the irony of history, that it's not very difficult to figure out who he was referring to as an expert, right? You know it, obviously. So, but that then feeds into policy ideas, policy programs, and it feeds also into funding programs, where the idea is always that AI will eventually replace fallible humans and inefficient humans, and so on and so on. And this might work very, very well in some areas where tasks are routine and predictable, and where humans really should probably be replaced. But in a field that is as social as healthcare, this is a very dangerous assumption. So I echo colleagues who said that what we want to avoid is that AI is really seen as a replacement of humans. And here I think the very notion of assistive AI, assuming that it will only be recommendations that human beings can then overrule. We already heard very wise things by other colleagues about how realistic that is in a very strong hierarchical system. So what is needed if we want to avoid that AI, especially in clinical medicine, increases technoscientific holism and crowds out high-touch medicine, which is actually the expensive thing in our healthcare systems now. It's that which I think, if we have a dystopic vision of where it all leads to, it will be not a two-tier medicine, but a medicine where the elites have access to boutique medicine with high tech and high touch, and 24-hour access to health professionals. And for most of the population, for everything that is not serious and not urgent, they will do with digital medicine. That's the dystopic vision. I think a utopian vision is also possible. But what do we need to get closer to the utopian vision, where we have strong investments into public infrastructures, into healthcare, into high-touch medicine, in addition to technology development? That's the utopian one. So the way to utopia is that when we think about accountability, and here I'm going to zoom in on accountability specifically, and responsibility, you can't really separate the two, we need to consider all phases of power. I'll say more about that in a second. We need a political ethics. I think the AI ethics scene is a big part of the problem, and we need a strong public value orientation. And all of those terms I'm going to say something about before I stop. So in my own discipline, where I was trained in political science, this is a very sort of seminal paper by Peter Dijeser, where he describes the different understandings of power. So the first phase, I'm not going to go through all the details, but the first phase of power is the only one that a lot of analysts saw for a long time, the phase of brute power, and forcing you to give me your money, otherwise I'll do something bad to you, right? That for a long time was the only phase that analysts saw. The second phase is a much more subtle one. It's really about suppressing agendas. So making sure that what you care about doesn't even get on the policy agenda. The third one is, as the slide shows, manipulation. So I'm manipulating someone into doing something that's actually against their interests. And the fourth one is the Foucauldian one, where all of us have internalized the rules and preferences of the ruling authorities, and we implement this on ourselves. We want to be good workers. We want to be healthy and fit and beautiful and so on. So the problem is that very often when we talk about power and inequalities and discrimination in the context of AI, we don't really think about the third, well, the third more, but not the fourth. It's really, the first one I think is quite easy to address. It's very visible, you have an open conflict. The second is also not really strongly addressed in the context of AI, and the fourth isn't either. So these are just a few examples of what it takes if we want to be attentive to all phases of power. The second phase of power, remember, that's the one where certain things don't get on the agenda. This means that we need to avoid bias in development, not only in terms of biased data sets, but also in terms of a bias in the ideas that will be funded by private and public money. And we could have a long conversation about how to do that, because it can't be that someone just decides for all of us, but we need to, this influencing policy agendas is a hugely important topic that it's not discussed enough. I'll return to that in my second point in a minute. For the third phase of power, we can, of course, avoid that people are manipulated. Manipulation doesn't mean that somebody nefariously tries to do that. But remember the saying that AI doesn't replace humans, but it turns them into AI. So that's the kind of thing. So human beings will eventually also be like robots. That's a part of, that's what the third phase of power says. You are doing something that is against your interest. You're working faster. We had this conversation this morning about radiologists, the biggest burnout rate, to the best of my knowledge, of all clinicians. That's the third phase of power, and also the fourth. So we need better training for healthcare professionals in a way that this is not another task that gets on their already overfull agendas, but training that is useful for them and doesn't limit the time that they have even more. And to address the fourth phase of power, we need more instruments of collective control and oversight, and also I'll return to that as well. So the second point, related to the first, let's be attentive to all phases of power. There's a huge amount of AI ethics guidelines. It peaked between 16 and 18, by the way, so it's getting a little less now. But hundreds and hundreds of ethics guidelines. Most companies, tech companies, have their own ethics boards, and on the ground, it's pretty much without effect. Why is it? One could say, yeah, medical ethics also took time to have an effect. I don't think so. I think medical ethics has quite rapidly had an effect on clinics, on clinical care and research. And I'm personally not sure that AI ethics will follow the same trajectory. Why not? Because of the very, very heavy investment of tech companies in not only funding AI, which would be fine in my view, but in AI ethics and regulation. So much so that in the context of the European Commission, it wasn't the European Commission, but it was an ad hoc advisory group with heavy industry representation. They also had lots of academics, but because they scheduled all the meetings on short notice, it's mostly the corporate representatives who were there. And the first iteration of their report was really pitting ethics against regulation, saying if we get the ethics right, we don't need binding laws. And that is, of course, a very, very dangerous path. And there are other examples of companies that fund endowed chairs, that give large grants to universities. And I don't think there's a need to reject all of this money at all times, but I think we need to be much, much more careful to avoid that agenda setting creeps in. Well, it has already happened, but we need to push back against this kind of agenda setting. This is the second phase of power again. Minority voices, minority views will not make it on these agendas. So then the third point, the third thing that we need to get closer to a utopian rather than the dystopian variant of healthcare within it is a stronger public value orientation. So we commented on this with regard to the AI Act, where we said that the AI Act's risk-based approach is overall good, but why is it that the risks level being equal, there's equal treatment of different tools and systems, irrespective of the public value they create? Why should a tool for a cosmetic company be treated the same as for something that can potentially alleviate health disparities or do other good things? So what is public value? Public value is, we defined it as something that happens when data use has clear benefits for either many people, for society as a whole, or for future generations, and at the same time, no person or group will experience significant harm. So we try to really not just say public value is important, but really operationalize what that could be for specific instances of data use. This is what we have done in the context of the research platform at the University of Vienna with his colleagues here on the slide. So Selim, who has been leading this with me, will defend his PhD in December. And part of that is PLUTO. So PLUTO is the public value assessment tool. And the tool is online. I'm not going to go into the tool because I don't have that much time, but it is, if you look for public value assessment tool, you'll find it online. What we base this on is that there are basically 4 kinds of data use. There's one where the benefits for real people are low. We know that it causes harm. And the risks are high. That should be prohibited. It shouldn't be made more ethical, it should be prohibited. Micro-targeting, some kinds of targeted advertising, and so on and so on. Then the opposite, on the opposite end of the scale, this is what you see here in type A, you have very high benefits for real people and very low risks. And those kinds of data uses we should make easier than they currently are. So here the call is for, in those cases, lowering regulatory thresholds and also sometimes making funding available, providing hands-on support. And the intermediate cases, type C and B, when you have high risks and potentially high benefits, then the risks need to come down. And when you have low risks and low benefits for people, then fine. Then probably the only thing that happens is that you have commercial profits, which is also fine, but more of the commercial profits than currently is the case need to be shared with the communities that make the data use possible in the first place. How could that work? We're currently thinking about the use of benefit sharing agreements of hospitals, for example, who share de-identified data with companies who then create software. So some of the commercial profits on this software needs to come back to either the hospital or the sort of catchment area. That's the idea behind it. And to assess the public value of specific instances of data use can happen through this PLUTO tool, and you see the URL here. So coming to the end, I said we need to reach this more utopian but rather than dystopian version. We need a political ethics, an ethics that doesn't make what's happening anyhow a little bit more responsible, but leaves the political economy untouched, doesn't change the distribution of power. So we need a political ethics, a sort of uppercase ethics. We need an ethics that also tries to get more democratic control over AI applications and regulation that does that. This is the implication of a more political ethics and also a stronger value orientation. We also need more democratic control over data and digital infrastructure. So the whole notion of accountability also needs to expand in terms of what it refers to, not only accountability for the decisions that different AI tools make, but also accountability for decisions that create the tools, create the infrastructures, and so on. And of course, we shouldn't limit accountability to developers and providers, but include also policymakers, regulators, and funders. And there are different ways in which this can be done. Funders can make funding dependent on meeting certain requirements, on reporting requirements. I'm also thinking of the National DNA Database in the UK. They used to publish, I think they still do, annual reports on harm that occurred as the basis of, resulting from their activities, on error rates and so on. So some kind of public reporting system would help as well to broaden the notion of accountability and also to broaden the scope of those who are held accountable. My last remark is, it's not only accountability towards certain individuals or groups of people, but this public accountability, I think, is also very important. Okay, I'll stop here. Thank you.